This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Good afternoon, everyone. So my brief has been to discuss calling criteria, particularly for maternity patients, in the context of identifying clinical deterioration early. So we all talk about track and trigger charts, and we sort of know that the purpose of using them is to identify clinical deterioration before it results in an adverse outcome for the patient, that we want to be able to detect the problem, record the documentation of the observations to make a decision: is this observation abnormality of any significance? Is an action required? How do we communicate that? What is our response going to be? And that collection of responsibilities is hopefully going to tip us along to the here we're going to improve rather than go here and get a complication. So that's the purpose of actually instituting these track and trigger charts. In the maternity context, we've got to sort of understand that childbirth is viewed as a healthy life event and not an illness, and that makes a difference to how midwives may perceive the whole body of knowledge around clinical deterioration. There's been a lot of discussion around medicalising childbirth, and that it may lead, and we indeed know it does lead, to unnecessary interventions, and it may hamper the new mother-baby experience. Early warning systems, are they to be used for every maternity patient, even those that are healthy, well and have not had any complication or medical intervention, or for what are considered high-risk maternity patients only? And what is our risk modelling like for how we determine what risk is in maternity, who is considered high risk, and how does that really compare to actually what happens? Because although we say someone may be high risk and we expect them to have a higher likelihood of an adverse outcome, that doesn't mean to say that a low risk woman is not going to have an adverse outcome. So there's a lot of discussion around how this really sits in the framework of a healthy, well life event. The UK have been absolute world leaders in examining maternal morbidity and mortality, and with a confidential inquiry to maternal deaths now for well over 50 years. And one of their most recent reports, it was the one prior to the last, basically said you cannot presume normality without measurement. And they're very strongly advocating that some form of observation for all maternity patients is required. And they also led the first idea that clinical deterioration and track and trigger charts, early warning systems, should be implemented into the maternity population. So they gave this recommendation for the first time in 2007. So you can see that's quite a lot later than where the general acute care sector were already established in this area. They recommended that early warning systems should be modified for maternity patients, that there was an urgent need for the routine use to be implemented for a national emergency maternity chart, that they should be introduced for all maternity and obstetric admissions in all clinical settings, including gynaecology wards, emergency departments, critical care units. This is back in 2007. This is an example of the chart they recommended at the time. It was based on one developed at Aberdeen Hospital in Scotland, and this is the first time a maternity chart had the human factor analysis elements incorporated within the chart. By 2012, so within 5 years of that recommendation being made, in the UK, there had almost been universal uptake of some sort of early warning system in maternity services, so that the antenatal patients, about 99% of services were using these sorts of charts in that environment, a lesser amount in labour, which I'll talk about later, and 100% of postpartum. Now, I say 100% of postpartum, but some of those areas only applied the tool for high-risk patients, not for all patients that had had a baby. What they also found, though, was that there was absolutely no consistent triggers. Some used an aggregate score trigger, so you had to count up, if you had a one minor physiological derangement in heart rate, but a bigger physiological derangement in temperature, you might add it up and say, yes, that triggers a problem. And others used a single parameter trigger, so if it was just one high blood pressure, that was enough to trigger a response. And you can see the range of trigger levels that were evident across the UK at that time. So a low-level trigger for respiratory rate ranged anywhere between 8 and 15. So if you had a respiratory rate of 14, it could have triggered a response. A high level, here the high level is 14 to 20. Temperature, similarly, high blood pressure and oxygen saturation. So there was no consistency for the triggers actually used to identify and create an escalation response. There has been quite a lot of debate on whether or not you should have specific maternity triggers or standard triggers, and as I said, the UK have advocated to have modified ones. I personally also agree that modified triggers are most appropriate for the maternity population, and this is because most women having a baby are relatively young, as in not over 50 compared to their general acute hospital environment, and less than 70 for the ICU one. They have less comorbidities in general than the general hospital population. There's very significant adaptive physiology of pregnancy that makes a difference and can make early detection more challenging in a pregnant population. You've got two patients in one, so sometimes you need to identify a situation that may have the baby at risk, but may not necessarily be such a dramatic problem for the mother. And there are pregnancy conditions that are very specific that may require your triggers to be more tailored to those events, and particularly high systolic blood pressure in the setting of preeclampsia. If a woman is sitting as an inpatient at 24 weeks with preterm ruptured membranes, suddenly temperature is much more relevant as a tool to identify potential clinical deterioration. So I would advocate maternity-specific triggers are better than standard triggers. Just if you're unaware of the physiology, I'm just going to do a couple of quick slides around the physiology, just to note that all systems are affected by pregnancy pretty much as soon as the woman gets pregnant, and that these challenges of the physiology work very well for women in normal healthy pregnancies, and most of the time the baby's born, there's no complications or adverse event. For some women, they may have an underlying cardiac disorder, for example, that no one's ever known about, that has never been diagnosed, but this sudden extra physiological challenge of pregnancy that's normal in pregnancy may actually create a problem in that woman and create diagnosis of cardiac disease for the first time. Spirometry changes very dramatically, so quite early in the pregnancy the woman has to blow off a lot more carbon dioxide than non-pregnancy, because the mother has to excrete the carbon dioxide from the baby, and the baby can only excrete the carbon dioxide by passive diffusion across the placenta. So the mother's CO2 has to be lower than the baby's to excrete the baby's CO2. So to do that, she breathes up, your brainstem actually changes its sensitivities and increases ventilation, mostly by increasing breath, tidal volume. Normal blood gases are quite different in pregnancy, and again, these changes occur early. So if you had a blood gas on a pregnant woman who was 8 weeks pregnant, you'd find these sort of gases, rather than what you might expect otherwise. And these are normal, so this is your normal parameter to compare to. Cardiac output increases quite dramatically, again, from quite early. So the first time they've measured this is at around 5 weeks. It's already going up. Cardiac output goes way up, up to 50% by early on, and is sustained for the pregnancy. Increases further in labour, increases further postpartum for that first hour. So there's very dramatic physiology. If you've got, I think I've got here, you've got extra cardiac output, you've got extra circulating blood volume, if you've got all that extra cardiac work happening, extra circulating volume happening, and you lose 1,500 ml of blood, your body can manage that pretty well for quite a long time, until you suddenly might have lost 3 litres of blood before you show any signs or symptoms. And so understanding these normal physiological changes and how they affect how you can pick up clinical deterioration is very important. Okay, so there's been limited examination of how useful or good these early warning systems are in a maternity setting. An anaesthetist in the UK looked at the maternity early obstetric warning system as recommended by the UK confidential inquiries, and in a single centre looked at it and actually found that as the tool was established, 30% of women triggered it, which is fairly excessive. 13% had morbidity. There was no mortality, no cardiac or respiratory arrests, and no ICU admissions. You can look here, they had red triggers, so these were the parameters used in this study. And if you had one red trigger, it triggered a response. If you had 2 yellow triggers, it triggered a response. And you can see that the ones that were most associated with a risk for morbidity were a high heart rate, a high diastolic blood pressure, a high systolic blood pressure, a high respiratory rate, temperature, things that are basically associated with the most common morbidity, which is hemorrhage and preeclampsia and sepsis. So, unfortunately, the way that these studies have been validated, they've used the items of morbidity as the outcome to measure the school's utility for, which means that it becomes self-fulfilling that, yes, the woman had morbidity. Because you've said to trigger the score, you have to have had morbidity. So it doesn't really make a lot of sense. A group in the UK also used the intensive care national data set that's for all intensive care admissions in the UK, and they had about 4,400 direct pregnant admissions to intensive care, separated the group into 2 and had half allocated to the group to develop the score and half set aside for validation purposes only. So about 2,200 women were used, and they did lots and lots and lots of statistical modelling to look at what parameters were going to be best to identify the best triggers for the maternity population. Keeping in mind, for this group, the outcome was death. So, and in an ICU population, it's about 3% of pregnant women who go to ICU. So it was still a rare event, but they found that, again, this was an aggregate-styled scoring system where you got, higher or lower scores based on degree of derangement, and then depending on what scores you had, if you had no triggers, then you just had routine observations, and they recommended 12-hourly monitoring. If you had 1 to 3, yada, 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 yada. This is a theoretical score, and it's not been validated in a clinical population, and certainly not in a maternity ward situation. Now, when you look at the validity of these sort of tools, the SING study, the anaesthetist study for the UK system, had very high sensitivity and specificity. The area under the receiver operating characteristic curve for the what's called the ICNARC constructed tool was really good. So these scores, they did their own statistical one that was the best performing for all the parameters they could identify and statistically find. Then they looked at that and said, well, actually, it doesn't meet what our clinical needs are going to be, so we're going to have to add things like, we know they want diastolic blood pressure, we know they're going to want this, or we're going to have that. So they then created a clinical one, which again was just a constructed tool based on what they thought was going to be clinically usable, which performed a little bit less interestingly. They then took the confidential inquiry model, they ran that one through their own validation data set. They ran another tool that had been developed by the Obstetric Anaesthetists Association, and interestingly they also ran one that was the Royal College of Physicians National Early Warning Score chart and triggers, and found that there wasn't a lot of difference and all of them performed super, super well. But keeping in mind, they discriminate very well at picking who's going to die and who's going to survive in an ICU population. And this one here is very good at saying, by using markers that indicate morbidity, that yes, they're going to have morbidity. And that if they don't have indicators indicative of morbidity, they don't have morbidity. So they're not actually, at the moment, we haven't got good endpoints that we're comparing with to validate these trigger levels by. So the difficulty is, mortality is very rare, so we can't really use mortality. If you've listened to some of the other sessions today, most of the METCOR criteria have been, the key outcome is, number of cardiac arrests and the reduction of cardiac arrests in the general hospital, unplanned ICU admissions, hospital mortality. None of that stuff is terribly useful in the maternity population. As I said, the SING study actually used morbidity descriptors as the measure of outcome, which you are then using as the endpoint, which just unfortunately is not going to be discriminative enough for you to use in clinical practice. We somehow need to look at whether the trigger resulted in an action. and whether the action was appropriate and timely, and did it prevent or contain illness. So how you do that is really the next question. And so I don't think at the moment the clinical utility of an obstetric early warning system or score has been fully investigated for us to know what's best. New Zealand did do a study of an early warning score in maternity patients, but it was at Auckland Hospital, and based on the advice of their resuscitation committee, they implemented a standard early warning score across the hospital because the resuscitation committee felt that it would be less confusing for all staff if the parameters and triggers were all the same. So they then picked up all their ICU maternity patients and a sample of their HDU maternity patients, and they then went back retrospectively, got the charts out, and then charted the observations on the early warning score chart, and then looked to see what cases might have been missed and what could have been prevented if the chart had been in use. Interestingly to note, in the Auckland Hospital at the time, there were 7 different types of maternity observation charts, and one of them had a place to record respiratory rate routinely. And not one case in all of the cases had a full set of vital signs recorded on every time occasion. Each case was then considered by the multidisciplinary review team, and then they determined whether or not preventability was present. So out of 64 cases, they felt that nearly 8% had cases that were preventable, 3 PPH and 2 sepsis. What I really want to highlight here, though, is this is the standard parameters that were used in their standard early warning system chart, and you can have a systolic blood pressure of 169 and still not trigger a case. And for a maternity population, we know there's a linear relationship with systolic hypertension and risk of cerebral hemorrhage, and that would not, in my mind, is not an acceptable level to say is okay to not trigger a case. And so I think this was a real missed opportunity. They should have done a whole lot of charting retrospectively back onto a modified maternity system and then compared them to see whether or not they would have actually had more cases saved if they'd used modified parameters. Regardless of what triggers are there and what's in use, there's always capacity to individualise the trigger response for an individual patient. So you can say in this particular time, the new trigger is if the respiratory rate is more than 30 or whatever you want it to be for the patient, and you can always redo that. So there's opportunities to individualise as necessary. I wanted to just talk briefly about the fetal neonatal perspectives. Outside of the standard Australian code systems, other maternity emergency codes exist. So, for example, code pink is an obstetric emergency. So, if someone breaks their membranes and has a cord prolapse, it might be an obstetric emergency, and then you might get a follow-up call fairly soon after. Code green, which is emergency caesarean. Caesarean gets done within 30 minutes from the call, is a standard order. We had Mercy Health has code white for massive obstetric hemorrhage, for example. I noticed on Ewan's slide this morning at Monash it's code green. So there's no standard for the emergency responses around maternity, but many institutions have them in place. They're just not part of the Australian emergency framework. And in a maternity setting, a paediatric code blue tends to be called for neonates, but at the moment in Victoria there isn't a neonate structure that's in place in use in maternity settings. Other unresolved issues, there's a discussion on whether or not the calling criteria should be the same for antenatal versus postpartum, or is individual customisation enough? What's the point of doing all your vital signs if no one checks the fundus? Because you can easily lose 2 litres of blood, have a stable pulse and BP and respiratory rate before they suddenly collapse. So you sort of need to consider other things. Intrapartum, this is a partograph or partogram for monitoring cervical dilatation, fetal descent, and strength and frequency of contractions in labour to monitor progress of labour. Maternal wellbeing, there's blood pressure and stuff here, but none of these at the moment here have been modified with that human factor analysis and how labour is monitored for maternal wellbeing. So I think the right calling criteria needs further research, and really challenging because they're rare events in a large number of normally well women. So it's quite tricky, and so I think clinical skill set, knowledge and proactive clinical thinking is really important. We sort of need to somehow manage to identify and respond to clinical deterioration that results in the best outcomes for mums and babies, but don't trigger a whole lot of unnecessary emergency responses. Thank you.